Thank you all for joining us this morning. We have Dr. Carlos Morillo presenting today, talking about atrial fibrillation from bench to bedside and beyond and personal perspective. And Dr. Morillo is well known to all of us. He sent me a short bio, which I had to make much shorter because he's done way too many things in his life. So I've narrowed it down. As you all know, he was section chief of cardiology here from 2016 to 2022 and a professor in our department. He was at McMaster prior to that in Hamilton. He was director of their AFib and syncope autonomic disorder group, and also director of EP prior to that there. Initial medical training was in Columbia, then at the University of Western Ontario in London, and then in Virginia. He has a lot of research interests, but his main interests are usually in around atrial fibrillation, syncope and autonomic disorders, and Chagas disease. He's had multiple grants over the years and many landmark publications, over 100,000 citations, and an H-index of 90. He has received many awards and recognition over the years, including being recognized as one of the 10 most influential Hispanic Canadians in 2010. He just returned from a one-year sabbatical as a senior visiting scientist at the Molecular and Novel Arrhythmia Mechanisms Group at the CNIC in Madrid, Spain. He has been involved in atrial fibrillation from bench to bedside over his career, so I'm very excited for his presentation today.
Yes, when you have to shorten your bio, it just means that you're old. Bottom line. So anyways, how do I advance the slides here? Okay, well, as I'm old, I also have a lot of conflicts of interest. So there are some of the clinical trials I've been mostly in the executive committees or steering. And I've been doing AF ablation since 1991, initially in dogs, 1998 in humans, and pigs since 2023 when I went last year to Spain. So I'm going to talk a little bit about that and mostly the labor on mechanisms, and really not going to get into clinical trials in AF ablation, just show a little bit of that and show some of the studies we were doing. And I'm still collaborating with the group there in Spain on trying to predict progression of atrial fibrillation. While we know that atrial fibrillation is prevalent, this is some stat data published a few years ago on the current epidemic of AF, and you all know about that, so I'm not really going to get into the details, simply that it's increasing with age, and we're going to have a lot of AFib, even by the time that some of us are not going to be here anymore, but you're still going to have that problem. So it's an aging problem, a societal problem that we need to look into. I'm sure you guys know who this gentleman is. Oh, you know, right? It is George Mines, Canadian electrophysiologist, very bright guy back in the early 1900s, did a number of contributions that continue to be actually groundbreaking almost over 100 years ago. And many of the things that he contributed were, looking at some of the circus movement reentry, spiral wave reentry that's become, again, a little bit of interest for a lot of people that work in atrial fibrillation mechanisms, the Libin circle reentry, et cetera. So he was actually a really bright guy that with no technology at all actually made all these predictions of, looking at the size of the circuit, that the anatomic obstacle was important for anatomic reentry, and functional reentry also describes some of these. So interesting to see that he did that. So this is me a long time ago when I started doing, I actually been involved in basic science since I was a kid, because I was a little bit of a rowdy kid and very indisciplined. And so my dad, who was a neurophysiologist, had a basic science lab. And because I had flunked a year, my punishment was to go to the animal lab and do some experiments. I'm talking about 1973. So I was 12 years old when I was given that task. And my father had worked at the NIH with a bunch of Nobel Prize guys that had worked there. But he was working basically in the reticular substance of the brain. So I had to do experiments on the reticular substance of the brain, putting electrocorticograms and recording stuff when I was 12 years old. And he made me read the Helsinki Declaration of how to, take care of people and animals and all that. So pretty much screwed since I was a kid. So anyways, here I am when I was with George. I came to London, Ontario in 1989. And when we finished, he would give you this laser pointer that way back then, this is 1994, so this is 30 years ago. So when they gave you a laser pointer, that was like, you know, you can become a speaker now. But George was actually, he was a really smart guy. You can imagine that I got there in 89, so in 1990, there's really no radio frequency yet available. So we did all the ablations in surgery with Gerard Gueridon. And he was already doing the corridor surgery, which I don't know if you remember. He would do a little slice of corridor between the sinus node, the AV node, and basically isolate both atria. And that was the surgery for atrial fibrillation. Same time, Mays and others were working on that. But George, who was a visionary, said, you know what, really, you know, we're going to get rid of WPW and all that. Nobody was going to care about that anymore. It's atrial fibrillation, which is the next frontier. And again, I'm talking 1990. So he was already predicting that atrial fibrillation was going to be an important thing. But he was also very smart in doing other stuff. This is the first implantable loop recorder that, you know, George designed. This is the elite pacemaker case. The first ones, I implanted them with Raymond and George back in 1991. We never thought that those things would become important for atrial fibrillation. It was mostly for syncope, but that's how it all started. And back then, so, you know, George gave me the task to look into atrial fibrillation. He said, you have to design a model of atrial fibrillation. And I said, okay, so how? And he said, well, it's easy. You know, you've seen people with AVNRT and WPW that if they go too fast, they go into atrial fibrillation. It's basically a rate thing. So you just have to make the heart beat really fast, the atrium, and you'll get atrial fibrillation at some point. But I want atrial fibrillation. I don't want a heart failure model. Okay, you know, I didn't have much of a background in that kind of stuff. So I actually had to go to Minneapolis, to Minnesota headquarters, so that they would get us the pacemakers to be able to stimulate at about 600 beats per minute. And I presented this in 1993 at it was the ACC meeting. And see this, the abstract at the JAC, with that title of an experimental focal evidence. And I got hammered. I got really hammered by someone that sadly already passed. It was Al Waldo, and the other guy that was the chair of that meeting, of that session. This was an abstract session, and it was for the Young Investigators Award, I remember. And so I got hammered by Doug Packer, was the only one that was kind of defending me. And he said, how are you talking about a focal mechanism? You're crazy. You know, you only had these little electrodes there. I have 360 electrodes that I put in the epicardium. This model is BS. And okay. So it was a bit of a thing. But, you know, when I started doing this back then, you know, we did show that there were some areas that were going a little bit faster. And, you know, we had to do echoes because, again, George didn't want LV dysfunction. So every 2 weeks I had to go and look at the little pig and do the echoes myself and measure the area and stuff. But, you know, and interestingly, the area of the atrium had to increase at least by 40% to have AFib sustainable. And, you know, when you go and look back at the, you know, you never invent anything. Everything has been invented. You only switch it around a little bit and make it look good. But, you know, Garrett had already talked about the left atrial mass in the 1920s. So I actually digged up that paper and I realized that he had done something similar and identified that. So, and the interesting part was that the first dogs that I did, you know, I'd put the electrode in the right atrial appendage, and the next day the dogs were dead. I said, and well, obviously I wasn't using active fixation. So at 600 beats per minute, the lead would drop into the RV and the little dogs would have VF. And George menaced me by telling me, okay, you know, each dog that you kill, it's coming from your salary. I didn't have a lot of salary way back then. So. And we also, I don't know if you remember Colette Gueridon. Colette Gueridon was Gerard Gueridon's wife. When they came to London, Ontario in the mid-70s. But she was actually a rheumatologist, but she couldn't practice as a rheumatologist. So she retrained herself as a cardiac pathologist. She actually was one of the best cardiac pathologists in Canada. And she did all the ultrastructural stuff for me. And, you know, we were actually the first to report all this disarray in the engorged mitochondria with the sarcoplasmic reticulum. And, you know, we even hypothesized that this was calcium overload. But again, it took me 2.5 years to get this paper published, up to the point that George actually was telling me, you know what, just forget about it and send it somewhere else. I said, well, no, this is a circulation paper. And I insisted, but, you know, I submitted this after the meeting in 1993, and it got flushed a couple of times until it finally got published. So for the younger people here, you know, be persistent, like atrial fibrillation, and you're going to get it done and published. So again, we were trying to figure out, well, are there triggers or drivers? And by the time this model was a little bit more advanced, because again, when I started doing this, I saw that there was an area, it was a little bit faster, and it was always in the left posterior wall near the pulmonary veins on the dog. And I was already doing my clinical EP, so I had to go at midnight and do these experiments. And in the lab, there was this cryo thing that Giordano had, in which he did these experiments also in pigs. That's where because remember that Giordano actually did atrial flutter surgery, AVNRT surgery, and all this he did with the cryoprobe thing. So I said, well, I don't know what happens if we put a little cryoprobe around there. And actually what happened is that it organized, it went slower. That gradient between, because you can see here in the previous one, there was a gradient between the left atrium and the right atrium. Left atrium was always faster. It was always consistent in that area, and that it terminated and went to sinus rhythm. And I tried to reinduce, and I couldn't reinduce. I said, oh, okay, this is good. So I showed that to George, and George, you know, if you guys know George Klein, he was like he looked at me like, what are you talking about? You know, just go back to your room and don't bother me. So, okay. But again, I was very insistent. I did another 20 dogs or something. Then I showed it to him, and he said, okay, well, looks like you got something there. Anyway, so we had to change the title of the paper because they wouldn't accept that this was a focal mechanism. So we had this really long, ugly title. So it's like everything, you know, if you go to a newspaper, the first thing, or any magazine, you look at the title, and you're going to read it because of the title. And a lot of people didn't want to read this one because the title was really boring. Of course, you read it, Alessi's title, atrial fibrillation begets atrial fibrillation. He completely screwed me with that one. That's a really good title. But you can see that there was about 6 months difference in the publication between Alessi and my study. As a matter of fact, Alessi cited our study in his paper. But if you go and look, Alessi's study has like 5,000 citations. Mine has only 3,000, which isn't that bad, but, you know, could have been better. Anyways, we did show, you know, again, things that you think in retrospect. We didn't talk about electrical remodeling, but we actually defined it. We showed structural remodeling with the change in the size in the left atrium and right atrium, of the ultrastructural changes. And again, this is this correlation between atrial fibrillation cycle length, and really the atrial fibrillation cycle length in atrial fib by that time hadn't been really that much explored. And I got the idea from some studies from the Dutch people, and there was this guy, Raul Coronel, that had done some stuff in VF, and he was looking at actually the VF cycle length as an expression of the refractory period. So I thought, well, if you do it in the ventricle, why not in the atrium? So that ended up working well. And then, you know, this has been documented to be actually what happens in most models of atrial fibrillation with electrical, structural, and infrastructural remodeling. And then back in 2002, Pepe, I was already at MAC, gave me a call and told me, hey, you still have the data from your dog model? I said, sure, what do you want? And he said, well, you know, can I look at some of your data? And we're looking at dominant frequency and looking at doing some fast Fourier and trying to figure out if we can figure out and identify triggers or whatever. So I gave him the data, and then he looked at it and he identified that, you know, these areas, the left atrium, were what he called, you know, mother rotors, and maybe there was some fibrillatory conduction, and this could be related with the mechanism of atrial fibrillation. So some baseline experimental studies, of course, Dan's done a lot. You know, I only did that one study and a couple of other things that we did with that model. And so there was some data that showed that experimental AF resulted in molecular, electrophysiological, and structural changes in these atrial myocytes, and that this facilitated perpetration of atrial fibrillation. So that's why, it would be important to try to intervene early to try to prevent that remodeling. And this comes from my good friend, Jerónimo Ferré, Jerónimo Ferré was the first fellow ever that Wellens had back in Maastricht. Then he went to Madrid and he started all the EP in Spain. But he's also a good friend of mine because he likes lots of wine, and he's the board of directors of the Real Madrid. So this year I ended up going to about 20 games of the Real Madrid and sat in the board's booth and things. So it was fun. So go for a sabbatical. It's always a good idea. So we know that there's some current remodeling in atrial fibrillation, and these currents may be important for determining how do we tackle treatment of atrial fibrillation. And there's a number of these, but there's some interest in the IKECH, and you can see the remodeling of these, or the patch clamping and the wholesale calcium currents. And you can see how the calcium currents are totally flattened with atrial fibrillation when it becomes, there's some differences between persistent and paroxysmal atrial fibrillation. And that may be a reason why the same medications that we use for persistent may not work for paroxysmal. Actually, the fact is that we only have one medication that we think works, which is amiodarone, and it doesn't work that well. So we need to focus our attention on some of this molecular changes to try to figure out some of the drugs we need to create to do that. And we know that there's some interest in changing some of these receptors, and I'm not going to go into all the details. I'll show you some data later on the KACH, in which the group there with Pepe and others and myself have been working on, and show you some of that data. Now, what we do know is that there's this calcium overload from the sarcoplasmic reticulum, and there's RYR2 dysfunction, and there's also this CAMK2 activity that may be increased depending on whether this is paroxysmal atrial fibrillation or more chronic atrial fibrillation. And you can see that there's alterations in coupling and diastolic release of calcium, DADs, and changes in excitability that will turn into atrial fibrillation. And some of these mechanisms, depending on the potassium or calcium channels that are affected, may also lead to some reentry based on some different issues, including fibrosis. And we still, and that there's been a lot of movement trying to identify fibrosis by MRIs or with biomarkers. Some studies like the DCAF2 didn't really show that it worked that well. So we need to work around that area. And again, part of the problem we have is that if you look at this was published a couple of years ago by Pepe's group also. These are all the mechanisms that you can figure out on atrial fibrillation. So when you have so many mechanisms, it makes it a little bit difficult to target either therapy or target, a marker. So I think we need to improve that, obviously. And there's a complexity in the distribution of what people call drivers. This is from the Hazegaard group a few years ago, in which they used some spectral analysis thing to try to find where these, and I guess one of these went away. But anyways, what happens is with the progression of persistent atrial fibrillation, these drivers are moving around and are located in different areas. This because these are different areas in which there's more fibrosis or inflammation. Well, we don't know. Now, we know that there's some pulmonary veins. There's no doubt that the pulmonary veins are very important. But when we just take care of the pulmonary veins, we don't get rid of all of atrial fibrillation. And there's non-PV drivers also. And there's been many attempts with very different ways of looking at these mechanisms through mapping systems like the FIRM and others. And again, I'm not going to get into the detail. This is just to show you that we basically don't know what we're doing, because there's a lot of mechanisms that we haven't been able to pin down, and we don't have the mapping systems that work there. We know that there's some differences between right atrium and left atrium. And the left atrium, the coronary sinus, as you can see here in this, whatever color this is, pinkish, are the more prevalent, regardless of the type of mapping system that you use and whether you map both atria or no. And whether there's rotational or focal activity, which again, when you go and look at these maps, you kind of start thinking, how did they figure this is rotational and focal? You're making this freaking thing up. But then, I'll share some data that may help on that. So again, there's multiple circuits, Gary back in 1914, the multiple wavelets, Mo in the 60s. then what was the therapy? Well, so Cox and dogs did some maze that was very simple. It's kind of a roof line and pretty much isolating the pulmonary veins. And again, this has advanced quite a bit throughout the time, looking at the role of the autonomic nervous system, rotors in animals by Pepe, and targeting these with different mapping systems. Now, the truth is that trying to figure out electrical remodeling in human atrial fibrillation is not that easy. This was a sub-study that we designed from the CERT trial. Y'all remember the CERT trial was people that had a pacemaker, and we're just looking as whether if they had atrial fib and if that AFib was correlated with stroke. But I thought that it would be interesting to look at the mechanisms there if there was some remodeling. So that they had an atrial and a ventricular lead. So we would look at the refractory period. And you could also even measure, because this is from the bipolar atrial lead, it almost looks like a monophasic action potential, which it isn't, but it may kind of look like that. And if you measured the duration of that, you're basically looking at the refractory period. So we did a bunch of measurements. Bottom line, we couldn't really find any electrical remodeling there. The only thing we did find was that, the P wave duration and the sense in the pace P wave duration could eventually be correlated with the triggering of atrial fibrillation. So that was kind of disappointing. Now, just to remind you that, there's some studies that we've shown that we can prevent actually the progression of atrial fibrillation, but the progression of atrial fibrillation is slow. Not a lot of people progress to atrial fibrillation, just about 7.5% in the antiarrhythmic group against about 2% in the group that were on ablation. And you can see there that the progression is relatively slow, but we don't know why these patients with paroxysmal atrial fibrillation actually progress and why some don't. So there needs to be some further studies on that and whether there is some form of energy. Now we got all these types of energy with cryo, radio frequency, and PFA. I'm not going to talk about that, but interestingly, in this study, radio frequency, there's another Canadian study, the Circa dose, showed that there was no progression with radio frequency to persistent atrial fibrillation compared with two types of cryoablation, depending on time. So does the type of energy has anything to do with what it does to the tissue, that it can actually prevent the progression? Because if you look at the data, they both had the same impact on reducing the burden of atrial fibrillation. There has to be something more structural that the energy source has to be related with than anything else. And I'm going to skip some of this. So that we haven't been very good at trying to figure out what to do with paroxysmal persistent atrial fibrillation. And the studies that we've done with the tool, the STAR-AF2, hasn't really shown any difference regardless of the technique that we use. And trying to do some maps. And this is from Paolo Netti in Ottawa. He used to be one of my fellows. And we finished already the COAST-AF trial recruitment, which is basically randomizing people to a simple PVI versus just, trying to isolate those areas that have scar. And again, the study just finished recruitment, and they're probably going to present it sometime next year in one of the big meetings. Now the STAR-AF3, which is another study in which I'm involved and we're doing here in Calgary, we're trying to figure out if different ways of tackling this can lead to that. And again, we did the vein of Marshall, which wasn't that good and didn't show, it shows some improvement, but really, again, not that much. So again, we've used a lot of different things, and you can see lines, isolating the left atrium, doing a bunch of things has not really improved. Even looking at fibrosis with MRI, none of these tactics has actually improved what we do. So we do know that we need to improve our more precision medicine kind of thing. We know that there's a progression in time, but we don't know why that happens. But again, some people present with atrial fibrillation as persistent, and they're in persistent AFib all their life, and they have normal voltage. So why is that? Another present with this that is really just a scar as their first presentation. So we still need to figure out what's going on. So now this is some of the data from the lab where I was. This is prior to me coming there. So basically, this is a pig model, which they put a dual chamber pacemaker, and then about 10 days later, they do an AV node ablation. And then once you got, AV dissociation, the pacemaker is pacing at about 40 beats per minute. And then there's some high rate atrial pacing that goes about 20 to 30 hertz for several minutes, and then it stops and seizes the little pig goes into atrial fibrillation. And it's very interesting because these pigs are similar to humans. So the model you can see, actually, you see here the slope of the atrial fibrillation burden because we have two leads. We can detect the atrial fibrillation burden. And you can see this is one with rapid progression. So within 2 months, this piggy is already in persistent atrial fibrillation, which we would define being more than 7 days in AF all the time and not stopping at all. The pig would need a cardioversion. So he's in self-sustained persistent atrial fibrillation. But there's another pig here that has a very slow progression, some increased burden, and it takes him about 8 months to go into AFib. Same pigs, fed the same thing, live in the same farm, genetically pretty much the same. So why is that? Why does one pig, same age, everything? Why does some pig, and this happens with people, and we need to figure out that because I think that in the end, precision medicine, that's where we want to go. And this may provide us some information. Now they looked at the sham group and they looked at biopsies in both the right and left atrium. And you can see this is the sham operated and there's no progression in fibrosis, but you see that in the persistent AFib, all this gets infiltrated with fibrosis and particularly in the posterior left atrium, which is similar to what happens in humans. And then when you do some fancy mapping systems there, you can identify that there's both the right atrium and the left atrium, the coronary sinus, had kind of the presence of what was called the leading drivers. And again, I'm not going to get into the details, but they use this instantaneous amplitude and frequency modulations that they validated with Pepe and different groups and found that these are signals where there's some rotational footprints. And this was actually, these areas were associated with some particular findings there. So then what we wanted to do was, and this is where I became involved. So get the piggy, do the implant, do the AV node ablation, and look at progression. So we take blood samples from peripheral blood in the coronary sinus, right atrium and left atrium, and then we do atrial biopsies from 4 different spots with ice and in the left atrium. And these spots are actually have been identified from what we saw in the previous model where there was these drivers for atrial fibrillation. So we're actually targeting these areas to try to figure out, okay, are these areas have something in particular that's different? And, you can see the baseline, how the atrial fibrillation also becomes more chaotic. Atrial is like the cycle length. It's also shortened and the atrial area is getting increased. And these had long-lasting persistent atrial fibrillation, which is some of these piggies, we got them alive for about 2 years. Then we extract the hearts and do some cardiomyocyte cultures. And you can see here that there were some regional specific changes in cardiac resident macrophages and fibroblasts, because we know that there's inflammation has been very much involved with atrial fibrillation. So we wanted to look at that also. So there's a sham operated group, and you can see that with the staining here, there's some increase not only in fibrosis and the mRNA. We looked at 1 beta and IL-6. This didn't look that impressive. But again, if you look at some of these maps, these are cluster maps trying to look at where these populations of non-myeloid and fibroblasts were. You can see that there's a very different distribution between and mostly fibroblasts and myeloid cells. Why is that important? Because these may modulate some very specific inflammatory and pro-fibrotic responses in these specific areas. And we're also looking in some of these genes, trying to identify which genes were related with that. And some more fancy stuff here that looks at some of the clusters at these fibroblasts. And there's another one that I'm not showing here, which was the PXT3, that I'll talk a little bit later. These heat maps that show that they were distributed around the left atrium and the right atrium also. And looking at, so there's 2 parallel studies. Actually, these are 3 studies. So one was the model that I just showed you, the rapid atrial pace model in pigs that had no structural heart disease. Then we know that there's a lot of people out there with coronary artery disease. So we did a model with an infarction at the circumflex to see if ischemia and scar there, also with some scar in the left atrium, would have anything to do. Here's the pathology showing some scarring in the left atrium. But interestingly enough, there's actually no difference compared they also had the same amount and proportion of atrial fibrillation than the other ones. And then there's a translational study, and this is in humans. So basically at the San Carlos Hospital, we would go there and patients with persistent atrial fibrillation and more than 2 PVIs. What we would do is that, they would go and have this mapping and get some of the ablation done by radio frequency, and then go and have a minimally invasive surgical left atrial isolation and some further ablation and mapping. And we'd take biopsies of both left and right atrium to try to do these maps again. And interestingly enough, I'm just going to go to this one down here, E. You see here's the sham human and the sham pig. Basically, they correlate quite well with only one exception. So we saw that these two models are very similar. And you can see here the common genes, almost 70% had common genes, including this PTX3, which apparently is an immunomodulator of both inflammation and fibrosis that may be very interesting to target in the future. So bottom line is that, there is some signaling there of both fibrosis and inflammation that were the ones that kind of correlated with the progression of persistent atrial fibrillation in this model. And this just shows the type of patients that we're doing, and if there was a leading driver or not. And, basically, again, this is in the humans studies. We could identify these areas, and then we would actually go and do some biopsies of those areas, make some cardiomyocyte cultures of those, and tackle these with ablation. So pretty complex study, but actually what it showed is that there was some underlying regional adaptive changes in non-myocyte populations that may be important, particularly fibroblasts and myeloid populations, in modulating this. Why is this important? Well, we can target these, and eventually, it was interesting because these areas where there's a lot of inflammation and these drivers are coming from, there was this PTX3, actually what it does, it reduces fibrosis. So these areas don't have a lot of fibrosis, and then they may be able to maintain this. So, there's been this attempt to do this in humans with, imaging, trying to look at fibrosis, and eventually try to personalize the ablation in people. Now, the other problem that we have is that we have a lot of antiarrhythmic drugs. None really work that well. We haven't had major developments since dronedarone. And you can see this is from one of the trials. This is the loop recorder. And it shows, a pretty nasty one-to-one flutter and, sometimes some even VTVF. So the problem that we have with antiarrhythmic drugs is that they're not that good. You remember the Palace trial? There's more authors than dead people. But anyways, the trial was stopped because there was remember the Palace trial that we used dronedarone as a rate control drug? Because with Stuart, Connolly, who rest in peace, and Jeff, we were looking at some of the data of the other dronedarone trials, and we said, well, you know what? It's pretty good to slow down the heart rate, so maybe we should use it at rate control. And that's where this came in patients with heart failure, and the study had to be stopped. So again, we know that we don't have very good drugs, but there's been some interest in trying to develop some like the KCH blocker, and that's where we've been working. And again, the group in Madrid, Pepe and David, and actually this peptide was developed, and TPN was developed by a group in the University of Southern Florida. So we know that if we can actually tackle this shortening of the action potential at this very specific spot, you can be very selective, and these receptors are only seen in the atrium. They're not in the ventricle, and this has been actually very well described. So, and they've looked at some structural bases. They looked at some optical mapping of this blockading of this potassium channel with a small molecule, and Samir Nujam is a guy that actually developed that for the group there. And they've used TQP, which is a venom that actually junctions with the peptide body, and then you can deliver that. Basically, it's been shown to work pretty well. So there's where the tertipin kind of locks in, and it's an important spot. So they do all these fancy maps there with 3D stuff, and you can actually develop this And what we've done actually is develop initially the liver of the mouse is the one that develops the peptide body. Then we transfer that to the pig and get the pig's liver to produce it. And once the pig's liver produces it, well, we take the pig's liver out and we produce this, and we start studying it both in cardiomyocytes and in the full model. So it's a lot of work, I can tell you that. So, and that's the peptide body, and that's the two places where it locks in, which actually has to do with CUR 3.14, which is a very important channel for preventing shortening of the action potential. And there's some data there that, again, I'm not going to go into all the details. These are the patch clamping data before and after giving these drugs. But just to show you that when you have sustained atrial arrhythmias and you give them dystrophin Q-induced termination, they terminate, and they also prevent remodeling by prolonging the duration of the action potential here. So it looks like these are pretty interesting molecules that may be working quite well. And again, we're using these in both types of model, the rapid progression and the slow progression. You can see that by looking at the slope here, we can actually predict when the pig is going to go into persistent atrial fibrillation. Before he does that, we inject them with this peptide body and take a look and see what's going on. So again, this is where we're at right now. We only have a few pigs that have done this. And we look at the phenotype and at the other things that I've shown you down there. This is me here doing one of my piggies. And I think I did like 22 pigs down there. It's a lot of work, I can tell you that, because these pigs take between 6 to 12 months to do that. But in addition to that, I was doing some other stuff like, extracting full heart bloods and putting them in a Langendorf and doing optical mapping. It actually was a lot of fun to do that. Pigs don't complain a lot because you're late for clinic, like I'm going to be late for clinic today, and all those things. But anyways, we've been looking at different biomarkers and different pro-collagen type 1, et cetera. And you can see that there's some differences in progressing in those animals. And that's the experimental design. And again, not going to go into that, but we got these 3 different groups, and hopefully we'll get some further data soon. Other stuff that we're doing is also trying to look at some of the genetics, but more the epigenetics, to try to identify if there's some epigenetic markers. And, we looked at the MYL2 and histones, and there's another one here that seems to be quite promising. There's the RCAN 1.1, which seems to be very overexpressed at the protein level in these animals. And actually, we already have some human samples in which this seems to go the same place. So just to wrap it up, there's, I think basic science is very interesting, but, we need to do translational science, because we need to move this forward into what we can do with humans and eventually get some clinical trials. So what we're doing now is we're almost going to get ready for a phase 1 with this peptide body. And once we get that peptide body approved, we'll move for a phase 2 or phase 3. Probably be dead by the time we get to the phase 3, but that's okay. Anyways, just to show you that, so what I've been doing for the last 30 years, I've been looking at models, but I've also been highly involved with ablation. So I think that we can actually look at all this and try to use our patient data, now that we have all this big data, in a better way to try to understand these mechanisms and improve the management of atrial fibrillation, and also characterize a little bit better this atrial cardiomyopathy staging. There's a proposal that was published this year in the Spanish Journal of Cardiology at looking at the early no remodeling and immediate intermediate modeling, and if with some of these biomarkers and some of these advances that I've spoken to you, we can get there. So these are the teams there. These are big teams. I was actually surprised by that. Yeah, Pepe and David each have about 15 people working with them, either postdocs, PhDs, or established scientists there. They have these 2 basement EP labs with all the 5 mapping systems and 2 5.5 Tesla MRIs and CT scans. So the animal comes into MRI first, CT scan next, then comes to the EP lab. So an infrastructure that I was actually quite envious that I hope we can reproduce here. these are the two kids that actually helped me the most. One is a very, very fine young man. He's doing his PhD in genetics, and we're doing all the epigenetic study. Eva is already an electrophysiologist. She's down in Granada, but comes once a month and spends 2 weeks there doing some of the mapping stuff that we do there. But of course, I do a lot of hiking. People know, this is actually the origin of the Garonne River. You know what the Garonne River is? Garonne River is the one that goes through Bordeaux. So I got 1 foot in the right bank and 1 foot on the left bank. You may not know, but these are some of the most expensive and greatest wines in the world. Here, for example, the right bank is Petrus. A bottle of that goes for $10,000. I'm not telling you if I drink that, but Anyway, so I did a lot of hiking. It was a great year. I would strongly encourage people to do a sabbatical, but don't just go and hike and drink wine, do some science, because it actually makes you feel much better. And I went to 25 games of the Real Madrid, it was an amazing experience. So this is where football, not soccer, football really is great. So thank you again. If there's any questions, I'd be happy to answer them. Oh yeah, it's a beautiful stadium. Yeah, the Bernabéu, the new stadium.
Thank you, Carlos. That was a great tour of bench to bedside for atrial fibrillation. Any questions? Okay.
Yeah. No, it's in humans also. Yep. Only in the atrium, yeah. Yeah. Yeah, well, I didn't have time to all the stuff. Yeah, that the lab there, because the question was that if the KCH channel is also in humans and in mice, can you do some knockouts? And yes, you can do some knockouts with that. Pepe, I didn't show all the other stuff I was involved also because this is only Fib. Actually, they have some knockouts of a short QT and of the Anderson-Tawil syndrome also. And as you know, Anderson-Tawil syndrome, which is the long QT 14 or something, they also do atrial fibrillation. So there's other stuff that we're doing with them, and a couple of papers are coming there with the knockout in the wild type, looking at flecainide and other antiarrhythmics, but also trying to test this peptide body there. Yeah. Well, the KR 3.1, 1.4, there's different ones because there's a NAV and there's other ones. But they've actually shown that these, when you do patch clamping, they also modulate some of the action potential duration, and they also are related with some after depolarizations. So and by locking on the K1, the KCH, you can inhibit those also, apparently. The peptide body, well, most of the new drugs for cancer have been developed with peptide body technology. The peptide body is basically just an autoantibody that you can design to go on and lock in directly to any specific receptor you decide. And that's how some of the new drugs in cancer were designed. So based on that principle, Pepe and the group said, well, why can't we do this for an antiarrhythmic? And that's what they've done. So peptide body is an autoantibody that is designed to go into a specific receptor that you can design to go there. Not that easy, but that's how they've done some of these cancer drugs. And we're translating that knowledge into antiarrhythmic therapy. Oh yeah, terpene. That's a venom that's been used for ages that goes and locks into those receptors. Oh, those are different, but the idea is to try to get rid of the terterpene and only get the peptide body done, which is already, I had nothing to do with that. I just groomed the pigs. But yeah, the group in Florida and the group in and Madrid has already done that. So now it's the peptide body does not need the tertipin to lock there. The tertipin is like a transporter, basically. Yeah, Rupi, sex difference. Yeah, actually, we looked at the pigs, and we haven't seen any major sex differences for now. The human study only had like 18 patients, and unfortunately, the majority, like 12, were men. So, still working on that. Yeah, great question. And what we've seen is that, yes, apparently, but again, this is very preliminary data because we're just starting to produce the peptide body through the liver. But, because your point is well taken, because one would say, well, there's a lot of fibrosis, really, you're not going to be able to lock into that receptor. But remember that the other stuff that I showed you from the initial study showed that these fibroblasts actually were showing that in these areas, at least where the drivers are, there was not as much fibrosis. And actually there was kind of modulation of the inflammation. So what we think is that these drugs target cells that are still in the driver regions. They would still lock into the KACH receptor. But that needs to be proven. Oh, sure. Yeah, the question was, is that fibrosis would have any effect on the KACH receptor? And the answer is yes. But the response was that, in some of these driver regions, apparently there's this modulation from fibroblasts and myeloid cells prevents some of that fibrosis. So hopefully in these driver areas, this peptide body would lock in there and work. To be proven. Yeah, good. Yeah, these are Spanish pigs, so acorns. Yeah, that's a good question. And they haven't modulated any of those, but there's some idea of trying to do that, looking at some environmental factors to do that. And there's some of this data, and there's another, they did also some of this in humans, but looking at the data from patients that had devices. And they found these same curves of rapid progressors and slow progressors. And part of it was the time it takes to them to actually shorten their atrial fibrillation cycle length. So people shorten their atrial fibrillation cycle length fast within the first few episodes of atrial fibrillation, they're going to have a very rapid progression. If they don't, they seem to be more progressive. So that's one of them. And they looked at other risk factors, and apparently obesity was one. And they're looking at markers of inflammation that could eventually be that, but that data is still under review. But yeah, you're right. It falls into place with the RAST-IAF and other stuff that you guys are doing, which is quite interesting. Hey, no, thank you.
Great, thanks.